So we talk about intestinal permeability, right? So let's talk about how we can optimize gut microflora or microbiota. Again, this is much more complicated than dealing with leaky gut because there are a lot of kind of problems associated with that. So first of all, there are several products which target that particular issue. So most of you know what probiotics are, right?
Can you speak a little louder, please? Yeah.
Most of you know what probiotics are. So probiotics are live microorganisms which kind of populate our gut and can improve microbial balance. Prebiotics, I don't know if you know what prebiotics are, but prebiotics are poorly digestible polysaccharide. So they're fermented by our own gut microflora and then they support it. So they're kind of feeders of normal bacteria. Symbiotics basically means it's a combination of probiotics and prebiotics. Butyrate can also feed normal gut microflora. And finally, digestive enzymes. And digestive, we'll talk about that in a few minutes. So these are the group of products which are available to improve gut microflora. So what do we know about clinical trials in patients with spondylitis? Well, there are only 5 publications about probiotics in spondylitis. Publications are very confusing. Clinical trials were designed in a horrible way, so the data is inconclusive. So one trial said that probiotics do benefit, 4 trials said they don't benefit at all. So, but again, the design is horrible. So one trial was done using internet. So, and there are only trials been done in the States. Most of them came from England and New Zealand. So what are the problems? Well, first of all, a limited number of published trials. As I said, it's one problem. Second, the number of participants to make any definitive conclusions was very limited. Design was horrible, and they didn't use any clinical or laboratory markers to measure outcome. They used basically joint pain as an outcome, and you cannot do it. So, and again, the design was also poor because they used low-dose probiotics, poor selection of strains, and so on and so on. So if you look at the clinical data from the trials, you'll be very confused. So when we're dealing with probiotics, what's the most important stuff? So it's the right dose. So the dose of probiotics comes in billion CFUs, right? So most of the probiotics which are sold in the stores outside, they come in 5 to 10 billion CFUs. It's nothing. It's pediatric dose. So for adults, even for maintenance, it's not going to do much. If you look at prescription probiotics like VSL number 3, double-stranded, it's a 500 billion units. It does make a difference. So, but again, 5 or 10 billion, it's nothing. So the right strains. So right now, there are approximately 20 different strains which are approved by the FDA to use as official probiotic strains. And they all have their unique niches. So some of the strains actually producing enzymes, and they can be used for patients with various enzymatic deficiencies. Like there are a couple of strains which we're using in our clinic. They digest soy, they digest gluten, they digest meat. So you can use them for digestive purposes. They do nothing for the inflammation. So there are certain strains which are designed for particular conditions, like there's a probiotic called Saccharomyces boulardii, right? So this probiotic is used when you have yeast overgrowth, when you have also C. diff infection, and when you have H. pylori. So this probiotic is good for specific conditions. It doesn't work for anything else. In our clinic, we're using, for inflammatory purposes and for patients with spondylitis, we're using a strain which is called Bacillus coagulans. So if you look it up online, last year there were 2 main publications. One came from Cleveland Clinic and second from Europe. So Bacillus coagulans is a very unique strain. It's a spore-forming strain of probiotic, so it means that it stays in your gut much, much longer. And then it has the strongest anti-inflammatory activity compared to other strains. So Cleveland Clinic published an article comparing actually Bacillus coagulans use and Remicade in patients with arthritis, and they found that efficacy was comparable to Remicade. So then the article was published in Europe comparing Bacillus coagulans and Remicade in patients with ulcerative colitis, and results were fantastic. So no data about spondylitis in publications. We use it for a number of conditions. It does work. It does make a difference. So in general, outside of our clinic, the strain is available as max 5 billion units with 25 billion units per capsule. So what else you need to know about probiotics? It's very important when to take probiotics. So if you take them with meals, they don't work. because they don't serve the purpose. So they need to be taken on an empty stomach, either 30 minutes before meals or before bedtime. And then a lot of patients don't realize that probiotics are like microorganisms, and they can be killed by disease-modifying drugs like sulfasalazine kills most of the probiotics. Methotrexate kills most of the probiotics. Even Plaquenil, which is an antibiotic, can kill probiotics. So you need to space out probiotics from DMARDs and definitely from the antibiotics. All right? And you need to talk to a physician, whoever prescribes you all these things, how to administer these things, because otherwise you'll be taking probiotics and won't see any effects, not because they don't work, but because you use them in the wrong way. What about prebiotics? What do we know about prebiotics? Again, prebiotics are large polysaccharides, so there are no single published clinical trials using prebiotics in patients with spondylitis. There's some data about prebiotics in patients with colitis and Crohn's disease. So there are some issues with prebiotics and spondylitis. What's been shown that in patients with colitis and Crohn's disease, prebiotics can trigger severe inflammatory response, and specifically prebiotics which contains beta-glucan and non-polysaccharides. And so in our clinic, I prefer not to use prebiotics in patients with spondylitis. So, and again, when you're buying your probiotics in the stores, just check whether they have any prebiotics, because most of the probiotics are mixed with prebiotics. And you need to be aware that, again, if you develop reaction, maybe not reaction to the probiotic, but rather reaction to the prebiotics. So just pay attention to details.
Yes. What would the reaction look like?
Worsening of the joint pain, bloating, inflammatory reaction. In patients with colitis, they develop basic bloody stools.
And eczema?
Eczema maybe, yes. So basically systemic inflammatory response, right?
Mm-hmm.
Again, there are some other prebiotics. I couldn't find any data, so there's also FOS, which is fructose polysaccharide. Again, I can't find any data, but I personally had a pretty bad experience with a couple of prebiotics in my patients. I decided not to use them in patients with specifically spondylitis. So what about digestive enzymes? So enzymes right now are getting more and more popular, and so what's the reason why they were used them in patients with spondylitis? Well, there are several reasons. So it's been described again in 80s and 90s that patients with chronic conditions, including long-standing spondylitis, they have deficiency of digestive enzymes, mainly because the function of pancreas goes down. So it's been described. So what are the consequences? Well, if you eat meal and your meal is not completely digested, so large fragments of the food that end up in low portions of your intestine, and they can trigger actual fermentation process and yeast overgrowth. So it's been described. And so to prevent this, you need to use digestive enzymes. It's pretty much the rule of thumb in our clinic. So there are different digestive enzymes available, so you need to know which one you're using. So they actually differ in their strengths. So the weakest enzymes are enzymes which originate from porcine or pig pancreas. So there are several products on the market under the name pancreatic enzymes or pancreatine. So the good thing about these enzymes that they're approximately 95 to 96% chemically identical to human enzymes. However, they work in very narrow range of pH, and so they're easily neutralized by acid environment of the gastric juice. So these are low potency enzymes. Step up are plant enzymes. So these enzymes which come from tropical fruits, mainly from papaya and pineapple, and they work in broader range, and so that's typically what we use in most of our patients. And finally, you have super strong product, which enzymes, we call them vegan enzymes. So these enzymes come from mushrooms and medicinal molds. So these enzymes work in very broad range of pH from like 2 up to 12, and they pretty much digest everything. So they're not suitable for patients who have gastritis because they can irritate gastric lesions. But again, for patients without gastritis, that's probably the best product. Again, enzymes are taken after meals or with meals, never ever taken before meals because they can irritate your stomach.